Thank you all for being here in the discussion of the liver session presentation. We had three wonderful presentations from three different universities. And first of all, I want to thank all the speakers for being here. And I have questions for the first speaker, Uday Sakumar from the University of Stanford. Uday,
yes, sir.
Well, there's an interesting effect that we had in your study that you were commenting. This effect, this hot to cold effect that
yes,
you were
yes,
calling.
yes. Yes.
Can you comment on this?
So in our research group, we have been predominantly exploring on delivery of microRNA loaded nanoparticles to the tumor. But in a recent study, we have come across that there is a sudden spike or increase in the cytokines in the treated tumor regions. So definitely there is some role of ultrasound and microRNA, both combination in instigating that this cytokine storm in the tumor locations. And what we expect to explore in future is that this cytokine storm can be beneficial for therapeutic approaches if it turns over the M2 to M1 transition of macrophages and recruits the monocytes to the tumor location. Then we can also harvest the benefit of immune system along with the therapeutic strategies. Yeah, we're exploring on that line. This study just gave a brief hint on that. We are further trying to explore along that line, along the immunotherapy strategies. Yes, that was one of the interesting outcomes in this study.
Wonderful. What are your plans to follow up this study?
So as you could see in this study, we just achieved the delivery of microRNA, and we clearly showed that in the presence of ultrasound, we can increase the delivery of microRNA loaded nanoparticles in the specific tumor locations where we treat with ultrasound. But in the next study, we are trying to see the therapeutic benefits of increased delivery. So this whole study is about just showing the delivery is more. But the next study would be to see how this higher level of delivery is going to help us in overcoming the HCC in dog models, hepatocellular carcinoma in dog models. So we'll be doing it at multiple times during the course of study and try to see how HCC is responding to the microRNA therapy.
Wonderful. I don't know if some of the other speakers want to make a question to you.
Sure.
Peter?
I'll ask a question generally about microRNA therapeutics. I'm not the most familiar with them and their efficacy. Can you talk about maybe other models where these have been used and how efficacious are they?
So in this study, I have used two different microRNAs. One is microRNA 122 and the other one is AntogoMIR21. AntogoMIR21, it basically, when that is delivered into the tumor models, the level of MIR21 is pretty high in HCC. So higher expression of MIR21 is responsible for HCC proliferation as well as metastasis. So we try to bring down the MIR21 level by delivering this AntogoMIR, which is actually complementary to that. Once this AntogoMIR goes in and binds to the MIR21, endogenous MIR21, it starts its degradation. So by degrading that, we bring down the MIR21 level and thus inhibit the proliferation as well as metastasis in HCC tumors. Yeah. So yeah, they do not have a specific target. They are still yet to be into the clinic specifically because they don't have a specific target. They do also have off-target effects. So we need to narrow down that. Yeah, that's one of the drawbacks with microRNA.
Gotcha.
Yes.
Wonderful. We're going for you, Peter Weber, histotripsy for the treatment of intrahepatic cholangiocarcinomas from Virginia Tech University. We saw that you used two models. One model of tumors that were separated, and then ex vivo, and then treatment in vivo. And you see differences between when you were treating cholangiocarcinomas, you needed to use more pulses than when you were doing it in the mouses. How do you explain that?
Yeah, so one of the differences we saw was more in the experimental setup. So the ex vivo tissues were taken from patients during their standard of care resection, and the sample sizes we got were relatively small. So we were using the clinical histotripsy transducer for these treatments, and the bubble cloud size was relatively comparable to the size of the tissues themselves. We believe this led to increased prefocal cavitation and basically more off-target effects from the focused ultrasound compared to the mouse model, where the actual target size of the histotripsy cloud was much smaller compared to the tumor size itself. So we were able to get more consistent ablations within the tissues and have a bubble cloud form within the tissue as opposed to more prefocal cavitation.
Another question that I have for you is that you were commenting in the study that you were planning to do this in in a more advanced fashion to treat tumors inside the liver, and how you're going to differentiate the stiffness of a tumor, of the stiffness of a duct or of a vessel, for instance.
Sure. So one of the companion studies that we've been doing in the lab is looking at the treatment of different structures around the liver. And so looking at the stomach, looking at the intestines, the gallbladder, different tissues, also blood vessels as well, and really characterizing the treatment of histotripsy on all of these tissues so that we can tell, how close can we get to some of these boarding structures? Can we treat a tumor that's right up against the stomach? Can we treat a tumor that's up against these bigger blood vessels? And some of the initial results we've seen is that we really do get a difference between especially bigger blood vessels that are stronger. The histotripsy isn't able to damage the endothelium of them. And so the theory, and something we definitely want to explore, is, can we treat tumors that are right up against them?
How does it work? It's a kind of, you tune the device to treat more strong structures, or it's just increasing the number of pulses that you do?
So we've been increasing the number of pulses as a sort of dose effect for the treatments. And we found in different tissues that the increased dosage, increased number of pulses, increases damage. And that's something we saw in this study where the not as strong tissues like HCCs or the liver parenchyma were able to be destroyed at a smaller and lower dose, versus cholangiocarcinomas, which are much stiffer, did not have as much destruction at those lower doses.
Okay. And what's next? What are you planning?
Next, it would be great to get a complete ablation of cholangiocarcinoma. So our study, we went up to 4,000 pulses for the ex vivo tissues, and it'd be nice to at least show that we can fully ablate these. We have good evidence that we've done a lot of damage. We did up to 75% damage at 4,000 pulses. So the next thing would be show complete ablation. And we're also looking to see exactly what we just talked about. Can we use histotripsy near these bigger blood vessels? These are the tissues that aren't resectable normally, is really a huge unmet need for cholangiocarcinoma. Only 15% of intrahepatic cholangiocarcinomas are resectable at diagnosis. And so, there's the 85% others that need some sort of treatment, and there's very few options. So we would like to see if we can, do something to help in those areas.
A question about animal models. Do you know if there is an animal model, a big animal model for cholangiocarcinoma?
I'm not familiar with a pig model. I know there's a mouse-derived cell line that we would love to be able to collaborate with the people who have that in order to do some more realistic mouse model treatments. The current one we used is a patient-derived xenograft, which is great because it gives us a realistic model for treating cholangiocarcinomas and translating it to humans. But we don't get the sort of interplay with the immune system and other factors that are important for treatment as well.
Thank you. I don't know if Uday, your colleague, has a question for you.
I have a small question. I'm totally new to the ultrasound-mediated ablation of tumor tissues. So I would like to know what Pete thinks about the mechanical index or safety of this ultrasound treatment approaches, because I am working on something which is a slightly higher mechanical index than the usual imaging stations, which is used for the therapeutic cavitation of microbubbles. So talking about the mechanical index, what is the range which he feels is safe to avoid tissue damage to the treated patients?
I'm sorry, the mechanical index of?
the ultrasound treatment, which can avoid the tissue damage in the treated region?
So I'm not entirely following your question here. Sorry. I'm not familiar with the concept of mechanical index.
Okay. See, a peak negative pressure of ultrasound, which is considered safe. Since you're ablating the tumor tissue, I think you're using a very strong ultrasound beam, right?
Right.
But in the case of imaging mode or in the therapy mode, which I have done in my study, it's a much weaker ultrasound beam. So is there a parameter to distinguish which strength of ultrasound or which operating parameter of ultrasound is safe so that it doesn't damage the tissue?
I see. With the diagnostic probes?
Diagnostics, right.
Gotcha. Yeah, so the transducer we're using is a 700 kilohertz transducer with a 500 PRF. So it's a much stronger ultrasound than your standard diagnostic probe would be. And so you wouldn't get similar effects in the tissues using a standard diagnostic probe.
Okay. I get it. So it's totally in a different regime. Yeah.
Yes.
Okay. Any more questions? I don't think we have more questions, and this is the speakers that we have. So I'm going to close the session now, and I'm going to thank you for your presence here. Thank you, the Focus Ultrasound, for allowing us to be together and comment this session on liver treatment with Focus Ultrasound. And thank you all the system that allows us to be here.
Thank you.